So our Vizient team, thank you again for your patience and the technical disruptions that we had the last couple attempts, but finally welcome to our presentation on how and why to plan for the what if scenario. Again, a little bit of background, my name's Gary Schindel. I've been in this pre-hospital and emergency management side as a clinician for 45 years, still certified. I'm an active member of the Central Florida Disaster Medical Coalition. I've also been involved in hundreds of healthcare facility projects around the world in the last 40 years, and I'm certified in a various number of hazardous materials and specialty certifications for pre-hospital deployment. What we're going to talk about today is the importance of emergency management and how the architectural design community can play a major role in supporting the response by emergency personnel, what emergency preparedness has to do with the physical environment, discuss some basic design options which will support effective surge response and what we have learned so far from the COVID-19 response, and what can we do now and in the future to prepare for another such event. So let's define mass casualty first and foremost. So a mass casualty incident, also known as MCI, is any situation where the number of injured needing care exceeds the resources available to perform care. Now, a lot of us think of this as local events. This could be a chlorine tanker overturned on the highway. It could be a brush fire. It could be an active shooter event. But in principle, it means any situation which threatens your employees, your customers, or the public, one which disrupts or shuts down your operations or causes physical or environmental damage. Or it can be any hospital in the U.S. in any afternoon on any given day. Many of you are closely tied to the end users. And, if you go down to the ER on a Tuesday afternoon at 2 o'clock in any major urban setting, you're going to find a busy ER. The picture on the upper right is one I took in a New York City healthcare facility in one of the major hospitals. Between the curtains, there are 3 patients with the head towards the wall, and then they've got the 4th patient along the foot end of each of those 3. So every cubicle has 4 patients in it. And this is what New York City hospitals are like on any given day. So that helps explain a little bit why when the pandemic surge came that they were so overburdened, because this was their normal condition anyway. Or it can be, of course, a new global virus blowing all our previous conventional thinking out of the water. So our friend Benjamin Franklin had it right when he said, by failing to prepare, you are preparing to fail. We have to look at what the potential risks are, and we'll talk about that here in a minute. And how we can best prepare for that, not only at the local but at a national level. Some of the most common misconceptions about mass casualty preparedness is that most emergencies are short-lived. And they're only as short-lived as the media allows them to be. So when the media is gone, the national spotlight goes away, but the people that are left homeless because the tornado went through, even down here in Orlando, the Pulse nightclub shooting, we're still talking about that. And it's almost 2 years, 3 years after it's happened. So again, it's only short-lived in the eyes of the media, but the people on the ground, and as we will find out in the long term with this COVID issue, it'll be around for a while. Other misconceptions, I won't ever have to deal with an emergency where I live. Well, because you're not in Tornado Alley doesn't mean you won't have to deal with an emergency, or in California you won't have to live with something else. And as this COVID virus has taught us, is that no one is immune to a mass casualty pandemic surge population event. How about there are a lot of emergencies I just can't prepare for? That's correct. You can't consider all of the what-if scenarios. However, there are some basic steps that you can take, some basic precautions that you can do on the front end of the design process and before a situation hits that are just the basics regardless of what type of scenario comes down the road. And what I want to do does not meet code. That's a big one we'll talk about later because that's one of my hot buttons right now. Is the code, and that we need to get together to try to figure out how we can change some of the state, local, and federal regulations allowing us to prepare. And then preparing takes too much time. We're all busy, we all have emails, and we're all worried about our HCAP scores in our hospitals, but you know what? When it comes down to an event like this, it has to be something we prepare for. So emergency preparedness is the managerial function, not the clinical function, the managerial function charged with creating the framework within which facilities and communities reduce vulnerability to hazards and cope with disasters. It's known as your vision or the disaster plan. Different people call it different things. But it is the way to seek and promote safer, less vulnerable communities, facilities, and give them the capacity to cope with the hazards and disasters. I mean, before this, the federal funding has always been tied to your annual inspection and ability to demonstrate that you've done disaster plans, and certainly we have a lot of federal funding involved now. So why do we prepare? So to tell you a little story, early last year, 2019, I was the evaluator for our Central Florida Disaster Coalition, and we ran a major drill exercise here. Involved 40 healthcare facilities, 60 municipal, county, state, and federal agencies, 1,500 victims, kids and parents throughout Central Florida were made up in Moulage, 5 different counties. The premise was a coordinated bombing and active shooter assault throughout the Central Florida region. In addition, there was a ricin chemical attack with a potential ricin release into the public water supply. A lot of people ask me then, why are we drilling at this magnitude or at this scale? Because something like this really can never happen here. Well, fast forward to Easter of last year in Sri Lanka. The only thing that was different from what we drilled for earlier that year and what happened over there was the lack of ricin attack in Sri Lanka. They had over 100 bombs in a good part of the country. The entire region was affected, 87 alone at the bus station. We have hundreds dead, almost 1,000 injured. So that is why we prepare. That is why we look at how we can manage events. We hope they never happen, but now we are in 2020, and guess what? We are a year later, and we have the most reactive worldwide healthcare event that we've ever seen in our lifetime. Now, some hazards just can't be eliminated. Tornadoes, for example, this was in 1998. The tornado that started here in Central Florida ripped through about 40 miles of Central Florida. This is kind of ground zero where it touched down. I happen to have been the first responder on the scene of this at 1 o'clock in the morning, pitch black, driving rain. And my partner and I set up a light mast and turned the lights on and had this. And about 6.5 hours later, we had taken 8 fatalities and 32 severely injured out of that pile with the help of a lot of other people that luckily came to our aid. But you can't prepare for everything, but you just have to have a frame of reference of what if, and then where do you go from here? So at any time when the capacity is overburdened, there will be by nature a compromise of many of the basics. The goal to preparing and for training for the worst case scenario is not to eliminate compromise, but to reduce and manage as much of the risk to the caregiver and to the patient alike. If we now go to Mr. Maslow's hierarchy of needs and we translate that into healthcare, and we look what the primary needs in healthcare are, the primary need is caregiver safety. And that is why you're hearing all over the media right now with this coronavirus, PPE. Nurses, first responders don't have enough masks, gowns, gloves to go around, because in healthcare, the primary foundation of a need is caregiver safety. Then we have clinical accuracy and safety. With clinical accuracy is whether it's the right medication. We're talking about the malaria drug. Is it right or is it not? But what are the methodologies of treating a patient? What is the clinical accuracy and the safety of that? That is the secondary primary need. Visibility, communication, efficiency, privacy, all become less important. When we'll talk about privacy and HIPAA a little bit later. But the last ones are ease of use and comfort. And I'm afraid that in the architectural and design community, we've had this completely backwards for the last several years. We have built these wonderful lobbies and these wonderful waiting rooms because we figured out that patients don't fill out the HIPAA paperwork that the family members and attendants do. So if they're comfortable, the HIPAA scores are comfortable. We need to get back to the fact that we go to Gemba at the very top, Gemba being the Japanese word for where work takes place. Comes out of the Kaizen, Kanban, optimization of workflow, language and vocabulary, but we've got to go back to where work takes place. In a hospital, work takes place wherever the patient can be found. So the goal should be to proactively manage and compromise rather than reactively deal with a pandemic or a mass casualty incident. Life safety should always be given the highest priority for caregivers and then patients. If a caregiver is compromised, it'll only further reduce the ability to adequately manage patients. There are coming close to 10,000 firefighters right now that are at this moment, which are quarantined in the United States because they were exposed to the COVID-19 and or transporting a patient or somewhere in the ER or family members. But as soon as you get caregivers going down, then all of a sudden you have compromise of care. So what are some of the design considerations as we move forward? What did we learn from this? Well, one of them that we learned from this exercise I was at is that the need for an emergency operations center is key. That is kind of the nucleus. Every hospital needs to have an effective, and I stress the word effective, Emergency Operations Center. The pictures on the bottom were from the hospital that I was evaluating. They had, 7 seats there in that room. There were no less at any given time for a 6-hour duration of 14 people in that room. They had one door. It was very difficult to get in and out, and it was very difficult to communicate to everybody at the time. So EOCs need to be outfitted with redundant phone lines, computers, additional electronic outlets, tied to UPS circuits in case even the main lines go down. Job action sheets, paperwork needs to be available. And according to the NIMS, Incident Management System compliancy. And command staff will have the reflective vests, so they need to be located there. Also documentation. Actual handwritten whiteboard documentation is a major benefit. You can do electronic documentation all you want, but when you need to go back and look at the board and say at 8:30 this morning I had XYZ beds available and I had how many staff coming in, and now it's 11:30 and how many beds do I have available, and you can at a glance look at that. In this particular scenario that I was evaluating, we ran out of whiteboard space. We had to photograph it, erase it, start over again, and learn that whiteboards are a good thing. Decontamination. There's a much larger, more decon area than you think required. Most ERs provide decontamination centers with about enough for 2 stretchers and a shower and a drain, not much there. But if you get 40 victims of a radiological, biohazard, or chemical event, then you're going to need to set up a tent outside and have a decon team available. So it's really important to know where that tent is going up. In this picture on the left, this particular hospital had some construction going on in the primary parking lot. The tent needed to be relocated from where it was originally designated outside the ER. But again, water runoff was a big consideration as to where it goes. You don't want it flowing back into your ER. The other thing is throughput or park. What do you do with these patients? And something we learned with the Pulse nightclub down here, that when the patient started showing up at the door unannounced, because the hospital was only a few blocks away from the incident, the staff was caught completely off guard. And then more and more people showed up. So they quickly realized that they were not going to be able to treat all these people in the ER, and they throughputed them to other areas of the hospital. Luckily, it happened at about 1:30 in the morning, and there was a lot of space in the pre-op, post-op areas that they could flex to. But this is, again, one of the considerations. What are we going to do with patients when they come in the masses? The picture on the left, where you can set up in a non-traditional area, a complete critical care environment, and bring wheelchairs and not necessarily stretchers, is a key point to that. And we'll show a short video on that application here. So what we have here is the Paladin Rapid Deployment Tripod Rail System. This is the fastest way to get equipment management into a non-traditional space. It's basically 2 heavy-duty robust tripods with an 8-foot equipment rail. And because the rail is dual profiled, we actually have 16 linear feet of rail mounting capability on this. So we can take, again, all of the PPE, monitoring equipment, sharps containers, and everything that you would require in a non-traditional space, mount it to the rail. It's off the floor, so there's no obstructions on the floor. We can get housekeeping, cleaning in there, and you can manage the devices as you need to. Right now we have 2 stretcher beds set up here. You can make it a 1-bed system, it doesn't matter, but you have completely self-contained oxygen, in this case an E-cylinder. We have our battery-operated suction canister here that, again, battery-operated, no electrical requirements, battery-operated monitor. So you're basically freestanding and completely independent of any infrastructure when you can set this up. You can go to a convention center, school auditorium, or a hospital lobby for that matter, a cafeteria. So again, all of the accessories provide you with your PPE. You can get your sanitizer and wipes and emesis bags and some basic storage. We have baskets on the backside. So, but it is a completely universal system that is immediately deployable. It takes about 2 minutes to set up and get everything going. So that is the Paladin Tripod Equipment Management Rapid Deployment System. So time is of the essence in all of these events, especially now we're talking about also moving critical care patients into med-surg patient rooms. So the ability to ramp up med gases without compromising the infrastructure is another key element here. So, if you look at the picture on the top right, there are mechanisms which you can bring into the design process on the front end, which will proactively allow you to expand med gases in a patient room without compromising, as you see on the right, with just splitter blocks on splitter blocks and hoping that something doesn't break or doesn't cause damage into the wall system that'll cost you funds downstream. So here's another short video kind of highlighting through that. I will probably fast forward through this one a little bit and just allow you to see more the application. So what we do is we have the rail on the wall, as you'll see here in a second. And it's trying. But what we do with the rail is then take the med gases and bring them into, come on. There we go. So we'll make real estate on the rail by moving accessories, and then we will take the gas block, and in this case it's an air block, and then we'll take that into the wall outlet, and then we'll do the same thing with the vacuum that you'll see here in a second. And we take the vacuum regulators and airflow meters of the hospital and use them, so it'll be a lot easier for them to just take the inventory they've got and multiplex. And then we do that same thing for the oxygen. We'll take that and set it up in two different locations, because oxygen is used more often than any other gas in there. So we can actually, from a single outlet on the wall, go to 4 oxygen flow meters and 1 power takeoff for a ventilator, all very easily. So that's the advantage of having a rail system in place, is that it allows you to upgrade any med-surg patient room. And more importantly, it then lets you take the stuff down after the fact for future use. So some hospitals are facing oxygen shortage, actually lack of tanks. It was a news story last week, because there's barely enough tanks to go around now. And when you build a 3,000 bed alternate care facility that virtually every patient needs oxygen in, then you have a problem with oxygen tanks. So what has been developed just very recently with one of our partner companies called Furno is a very high capacity portable oxygen tank system. This basically takes the place of an M cylinder, which itself weighs over 50 pounds, needs a cart and a maintenance person to come in and take out. So this is an oxygen delivery system that is 3,700 liters of oxygen with lightweight carbon fiber bottles. So it can be either wall hung or cart hung. And this video will show you a little bit more details on how that gets applied. So Paladin Healthcare manufactures the lowest technology device in healthcare. It's basically a rail and it's an adapter. But what we do is we take this and we use this as a platform to build a number of unique solutions. Under the current conditions with the COVID-19 crisis, we've taken our rail and adapters and we've applied it to create a complete intensive care environment in what would normally be a non-traditional care area. We can take any bare wall, and through the adaptation of the rail and the accessories, we can create full intensive care environments, including services for all of the PPE devices, masks, gowns, gloves, disposal areas, the diagnostic instruments that you would need. We also have the hand sanitizer, a battery-operated suction unit, so it's not dependent on wall outlets. And then most importantly, we have a high-capacity oxygen system, which is made by one of our partner companies called Furno. This is the equivalent of an M-cylinder oxygen tank, about 3,600 liters of oxygen, but they are in a very lightweight carbon fiber bottles. And the beauty of this is that someone at the bedside in full PPE taking care of a patient can actually swap out a bottle instead of bringing maintenance and service people with carts that you would with an M cylinder. So it's very simple to do. We unscrew this, the bottle comes out, and it's very, very lightweight and can easily be swapped out by any staff member at the bedside, again, not requiring maintenance or any carts. So again, with something as simple as our equipment rail, we have adapted just about any environment into a fully capable intensive care unit on demand and installs in literally 15 minutes. So that's, again, just the ability to do that in very short order in non-traditional spaces. Cross-contamination is another big thing that we've learned from COVID-19. And one of these, is better obviously than the other. These are both pictures of a deployment in a field hospital that I took, but one where we have no equipment management. And what they do is they hang the vital signs monitor on the side of the stretcher, and then every patient that comes into that location coughs on it, sneezes on it, bleeds on it. I can tell you that during a hectic deployment, the sanitation of cleaning that between patients is lacking severely. So again, giving it a home that is not right next to the patient is probably the better solution. And again, how do we manage on the front end for the next time a way to plan for this? We need to realize that in the architectural design community, that at some point when it hits the fan and we have mass casualty patients, that the visuals and the aesthetics are not all that important. We need to go back to Gemba, we need to go back to where work takes place, and we need to look at flexibility with space, and how can we flex up? So what if the hospital main lobby was designed to become an ER overflow space? What if the cafeteria was designed as a walking wounded gathering space where patients could reconnect with the worried loved ones? I mean, these are all things that are possible when we talk about this at the master planning cycle of design rather than on the day of an event. Staff and patients deserve at least the basics. That picture on the right I took at the University of Chicago. I took that picture about 9 a.m. During a week. And as you can count, there's the last picture there, it's 32H, H meaning hallway. So they've got almost 36 hallway patients designated for their ER on top of what's in their exam rooms. And what you're not seeing is PPE for the staff, hand sanitizer, sharps containers, any oxygen delivery for the patients, any vital signs monitors. Everything you see there is a compromise. And this is, again, long before COVID-19. Took this last year sometime. This is just Chicago downtown at any hospital, same thing as in New York, and same thing as any other major urban facility in the United States. So the picture on the left is better than the picture on the right because you have platforms that can bring you all the things as a caregiver you need to the point of care, to the Gemba, to where work takes place in a clinical environment. And this is, again, what we need to look at. So here's another short video just highlighting that application of the cart and what we can do to bring a mobile intensive care station to any location within a facility. So in response to this COVID-19 issue we have going on right now, Paladin Healthcare has refined our forward triage system into a forward treatment cart. What we've done is we've made all of the essential elements required for critical care medicine in a completely freestanding and mobile environment. We provide provisions for all of the PPE equipment, including the sanitizer and some diagnostic instruments, the sharps disposal, a portable suction unit that is not reliant on a wall connection, ophthalmoscopes that are battery operated, oxygen delivery that I'll show you in a minute on the back side, which is a high capacity oxygen system able to power ventilators in a very lightweight bottle manifold system. Mounting for monitors, and again, everything that you would need to deliver critical care in a very small footprint, portable environment. So if I spin this around, what we'll see is on the back side, again, some additional PPE, some wipes, emesis bags, but most importantly, it is from our partner company, Furno, very lightweight, man-portable, high-capacity oxygen system, which runs up to the flow meters, which they can access from the front. This entire system can provide everything somebody needs, whether it's a hotel, a convention center, any alternate care site for critical care, healthcare, with no compromise. At the end of the day, all of this can come off, it can be cleaned, it can be then decontaminated, it can be reset and used for the next event coming down, so you're not spending money now that you won't be able to use at some point downstream for another event. Completely portable. Most of it is also antimicrobial as well, which helps the fact of minimizing the spread of germs. Please call us if we can be of service. And what if gas outlets were pre-positioned behind artwork in the lobby, and now you can envision one of those carts being brought up, and even without that oxygen tank system, just plug and play, and now you can create a critical care station anywhere within the facility. This is where our regulatory agencies need to lighten up. This is where we need to lobby them to allow us to pre-plan and pre-position critical essential services like gases and electrical outlets in non-traditional places, allowing us to ramp up very quickly without having to go to the cost and compromise that always comes with a reactionary move like we've been doing lately. So let's talk about wayfinding for a second too. Wayfinding, this is kind of the common way of wayfinding that hospitals do when they get a mass casualty. Everybody in the business knows that green is low acuity, yellow is moderate, and red is I need help right now kind of thing. And it's great when people know where they are, if they're in a janitor's closet or what, but if there's nobody there, then they serve no purpose. What about lighting? How about we talk about incorporating lighting into our designs, that during a crisis or during a mass casualty event, we can literally flip a switch and then we can have green lighting directing people to the green area, yellow lighting to the yellow area, and red for the critical area. I mean, that's something that we've been doing for a long time with emergency lighting, is directing people under crisis situations to emergency exits or to other locations. So, why not try to incorporate that on the front end of the process? So a couple of lessons learned so far from COVID-19, and what do we still have to learn? So we've learned that alternate care sites are not a bad thing to think about. What if every public and government arena, convention center and such, excuse me, were pre-planned to stage emergency medical supplies? What if these venues, had a pre-plan so patients could be collected, triaged, and managed on site? That would be better prepared for the next event. I mean, COVID-19 is not the first time some of these facilities would have come in handy. At the Ariana Grande concert in Manchester in the UK, if they had a pre-plan for some mass casualty care there, they could have done it on site. Las Vegas shooting, but also natural disasters. After Hurricane Katrina, they used the Superdome. After Hurricane Harvey in Houston, they used the Convention Center. These are all examples of using non-traditional sites for medical shelters, and we do that for hurricanes here in Florida too, all the time. So, it's not that we won't have another event regionally, but it's something that we just haven't figured out the plan for. So, excuse me. So this came from the Army Corps of Engineers on day 24 of the response. So we had pretty much looked at 434 of different arenas that we could look at. We had identified over 13,500 potential beds, total alternate care beds, 14,800. But if you look on the upper right, that box that says engineered solution plans, approved site adaptations must be accomplished in as little as 5 days and no more than 2 weeks to align with state projected virus infection peaks. That is a physical and literal impossibility. So that's a really good idea if you can react that fast, but unless you pre-planned it, you can't do that. The American Institute of Architects last week on April 6th released a health impact brief that covers alternate care sites. And one of the things they did mention in there is experience from clinicians on the front line. Although hospitals have disaster plans in place, deployment of these plans with the rapid response pandemic has never been tested. It's unprecedented scale. And it's put our healthcare workers at risk. It also introduced a second document, which is the Alternate Care Site Preparedness Assessment Tool. In there, they have a very specific section for medical gases that they said provide accommodations for oxygen, medical air, and vacuum to support intubation and ventilator operations. So med gas is a big deal. You can't do something like this in 5 days or even in 2 weeks. It just doesn't happen. Unless we pre-plan for it and pre-position devices and tools that allow that to take place. One of the things that goes out the door right away in a field hospital is HIPAA. Privacy, HIPAA, out the door. And then again, there is no PPE provision for caregivers. You can have all the PPE you want, but if you don't put it at the point of care at Gemba, where work takes place, you're fooling yourself into a false sense of security. Now, this has all been done before. After the hurricane, Maria in Puerto Rico, one of the DMAT teams, a lot of DMAT teams deployed down there to support the healthcare infrastructure because all of the community hospitals were pretty much destroyed. So they did set up temporary hospitals in the arena. They had the advantage of not having to put the roof on their tents for that. But again, this has all been done before. We just never took it home and learned any lessons from it. Where we have set up field hospitals, it takes a lot of logistics. It takes air compressors and air conditioning units and electrical generators. There's a lot to setting up a field hospital. This is a 54-bed field hospital we set up here in Orlando for the Electric Daisy Carnival every year. We set it up underneath the bleachers of the Citrus Bowl Stadium. It takes days and days to set up. It takes just as much time to take down. But what if we could plan facilities like this and we build them which have plug-and-play infrastructure to allow air conditioning units to come in, to allow not having generators to be brought in, to make it easier to deploy. What if we took green spaces and parking lots and pre-planned them? This is the tent at Epcot at Disney. This is the critical care medical tent that I work in when they do the races. They do all the Disney marathons. If anybody's ever run that, hopefully you have not seen the inside of that tent. But again, this has popped up in the parking lot. I'll tell you that the Landstuhl Regional Medical Center for the Army in Germany. They're building a brand new replacement hospital, and that facility is planned from ground up to have mass casualty surge in its parking lots. They're putting electrical outlets and water connections there, so they know when they pop a tent, they don't need to run new lines out there. Why don't we do that every time we do a parking garage or a parking structure or anything associated with a hospital? It's not hard to do on the front end of the design side. And as far as portable tents goes, I mean, tents work really great in the spring and when the weather cooperates, but when you're in the winter, you wouldn't be popping tents in Central Park. And when you have a hurricane risk or a high wind risk, you wouldn't be putting tents up either. So there are alternatives in place to tents, as this video will show. And again, you know, the what if scenario. What if you could build an air-conditioned and off-the-grid shelter that allows you to bring anything in and call it a clinic, call it a facility. This is a company down here in Orlando called World Housing Solution. They've got clinics. They've set up a thing in 16 minutes. You can set up an entire structure that is hurricane-proof, fully powered, and easily transportable. It sets up in a trailer. And what if that trailer had solar panels on the top? And then you could power the entire thing completely independent of any grid requirements. And then in that trailer, you'd also have all of the equipment, the oxygen, the vacuum, and all of the PPE stuff that shelter would require. And then you could node these shelters and scale them up to whatever size you needed. So this is the kind of stuff that's out there. We just need to think about it ahead of time so we're prepared for it the next time. This is really one of my big personal issues, and that is why does an expiration date mandate us to throw stuff out? Both of these items come out of my personal trauma bag in my truck. The expiration date of 2012 on that burn dressing doesn't make it any less effective. It's still a good burn dressing if you need it. And that catheter to use for pleural decompression if you need to, it's still good. Nobody's going to care if they're laying there and need a pleural decompression at the expiration date was 35 years ago. So IV tubing, the same thing. In EMS, we don't watch the expiration date so much. We carry bulk equipment. However, it's a once and done scenario. That Orange County truck has enough stuff to care for about 400 patients, but there's no backup. Once those patients go to the hospital should be reliant on its own resources to support those incoming patients. So what I think we all need to do is get together with the regulatory agencies at every level, and they need to put an immediate waiver in place for all facilities and first responders regarding expired inventory. An endotracheal tube or bag of saline, which expired last week, is not going to be dangerous to use this week, next week, or even next year. You know, the problem is every time we have a Joint Commission assessment or inspection, you know, we scour the closets and the drawers for anything expired, and we send millions of dollars of those consumables to underdeveloped countries who use them for years to come. Expired inventory should be stockpiled at every point of care location at such a time and current situation that we have now. I mean, this is not going to be the last time we have to deal with this. So let us be prepared locally rather than reliant on a national stockpile of stuff that God knows is 20 years old. A friend of mine is an ER director out in Massachusetts. He got some national stockpile N95 masks, and they were brittle when he got them out of the box, so they were absolutely useless. Let's talk briefly about terminal cleaning. If you can't paint behind it, you can't clean behind it. If you're putting up temporary shelters, temporary structures, you know, cloth dividers, they can't be totally sanitized either. It's not worth the price or the effort to do that. So what we need to do, what must become the future of healthcare, is the ability to strip a room down after a infection patient had been admitted and turn it into a clean room, strip it down, able to clean down to the wall, because again, if you can't take it off the wall, if you can't paint behind it, you can't clean behind it. So again, this should be something as a standard of a design guide going forward, that every room should be able to strip down to nothing after an infectious patient has been there. So caregivers have got to defend their case. The architectural community can help. Technology exists to create these spaces and manage these patients. Flexibility, adaptability, expandability are the cornerstones of adequate management of surge populations, regardless of the cause or regardless of the location. So we got to get with our regulatory agents, equipment planners, and architects, as well as the local governments. So we have to, at some point, address the reality of non-traditional areas pre-planning on the front end of the process. So I encourage you to work with your design teams during construction projects, identify these hazards and assess the risks, assess the capabilities and resources that they have immediately on site, learn their emergency plan and procedures, and they'll be glad to share this. There's a lot of credibility that builds up when you talk to them about what their plans are, because they will be thankful that someone else is asking them and looking into it and how we can optimize these. How do we integrate the facility plan with the community plan, conduct training, attend drills? Public relations, it's always good news when you plan ahead, and then again, conduct drills. Even in your own offices, wherever you're located, you should also have an emergency plan. And then think outside the box, but more importantly, ask what if. And this is kind of what I've been doing pretty much all my life, is asking the what if scenario. You can't plan for everything, but I will leave you on that note with my favorite saying coming to us from our U.S. Navy SEALs, that the only easy day was yesterday. So we will have more difficult times coming up through the COVID-19 process as we come out the other end of this. But let's put our heads together and figure out what we need to do to never have to respond to something like this in a manner that we did again. So this concludes our presentation. Thank you very much for your time, and please call me if you have any questions or need any further information about anything we discussed here. Thank you again.